Morning, Krishni. I can confirm we're now live.
Thank you, Tom. So good morning, everybody, and welcome to our public meeting of the Integrated Care Board for Herefordshire and Worcestershire. I would like to just first of all note apologies. We have apologies from Paul Walker, Dr. Kath Cobain, and I think that's it actually for this morning, unless there's any other updates to be noted. We do have Rachel with us. Welcome, Rachel. Rachel Dunn, who is deputising for Kath in her absence. So welcome. I've had no declarations of interest other than the ones obviously registered already, declared in relation to items on the meeting's agenda. But if there is anything that anyone would like to highlight, please take a moment to do that now. Okay, I'll take that as none. So we move on to the governance log, including the forward plan. We do have a couple of outstanding actions, I think, from our action log. And the first of those is the Primary Care Access Recovery Plan, which was due this month, but nationally we've been asked to defer that to May. And the Best Value Care in the Right Setting report, which we have discussed in our informal development session, and will be coming to our May board, I believe. Hannah, is there anything that you'd like to add from the governance log?
No, Krishna, that's it. Thank you.
Great, thank you. So we'll just note those. Other than that, the actions are concluded. So minutes of the previous meeting, which was obviously our meeting of the 17th of January. Can I check with colleagues that you're happy that the minutes are an accurate reflection of our meeting? And then if that's the case, then I take it that we're happy to approve them. Thank you. So we will approve the minutes. And we move on then to our patient and public voice section today. Actually, we have no questions from the public for this meeting, so we've not received anything. And if there are any members of the public watching, then I would encourage you to use the facility to submit questions, because we're always very happy to take them, but we haven't received anything for this meeting to consider. So I move on to the people story. Now, unusually, as board members know, we would normally have a patient story for this, but the theme running through our meeting today is about our people, our staff, and therefore we have a people story today. And so I'm going to invite Katie Hartwright, our Chief People Officer, to lead that item for me. Thank you.
Thank you, Chair. Today's story is from a nurse in the NHS, and it's related to the impact of strike action. It's worth telling the board we did struggle, to be honest, to find a good story from across our system because of some of the challenges with the strike activity. And so therefore we do have one. We've spoken to somebody. I'm going to read it in the first person, and this has come directly from one of our nurses. So as a hospital nurse in the NHS, the decision to participate in the strikes wasn't one I took lightly. I love being a nurse. I'm proud to be a nurse, but I needed to take a stand when I felt we weren't being heard. My decision to strike wasn't related to my feelings for the trust, but more how challenging our role is with a dwindling workforce and cost of living challenges. I took part in all 7 of the industrial action days from December 22 to April 23. I felt very supported by the trust I work for. The executive team and senior nurses came out to see us on the line, and that was very meaningful to us. They made sure we had teas and coffees to keep warm, as it was very cold and wet while we were out on the line. We worked with the trust so they would understand how many of us were going out, because none of us wanted to put any patients at risk. The feeling on the line was very positive and cohesive. We were working together to improve our situation. I don't feel there were any repercussions from my decision to strike, either from the trust or my colleagues that chose not to strike, and it's all felt very supportive in that respect. Nurses faced real hardship through COVID, losing patients and colleagues. There was a fear of the disease and the trauma of losing people we cared for. but we were there every day out of a commitment to our patients. After COVID, there's been no real let-up as we're facing backlogs and increased demand. We've not had any real chance to recharge. This, coupled with a significant decrease in the nursing workforce, has put a huge amount of pressure on those of us still working. Pay was clearly a reason for the strikes. Despite the crucial role we play in the healthcare system, our salaries don't reflect the level of skill, dedication and responsibility required of us. Many nurses struggle to make ends meet, grappling with the financial strain of low wages in the face of rising living costs. While we did get a bump in salary after the strikes, it was almost immediately eaten up by the rising cost of living we're all facing. Understaffing is the main reason I went out, however. I care very much for my patients and I want to be able to deliver the best care I can to them, but that's not always possible in the current environment. Every day on the job, I witness the consequences of understaffing firsthand. We are stretched thin, forced to juggle a lot of patients, and I worry about compromising the quality of care we provide. We are still relying on a large number of bank and agency staff to cover vacancies, and those staff need extra support because they don't know the area they're working in. And while they're a great help, they'll never be as good as a substantive nurse on a ward. When we can't cover shifts, the rest of us have to pick up the work to ensure the patient's needs are met as best as we can. I worry about who will come into the profession though. There is no bursary now, so less people are going to university. The job does take a toll on both my physical and mental well-being. Shifts are long and there are times when I may not even get a break. The stress and worry of possibly making a mistake in this environment is an immense pressure on me and my colleagues. Ultimately, the decision to strike was born out of a deep-seated desire for change, not just for ourselves, but for the patients we care for day in and day out. In reality, we came together and we got a pay increase, but not much has changed for us since the industrial action. The trust has been supportive, but we still face challenges with capacity, and that continues to impact on us. Thank you, Chair. That's the story.
Thank you very much, Katie. Thought-provoking, I'm sure everyone will agree. And just again, as a reminder, I think some months ago we decided that we would sort of focus on well-being, particularly in the context of industrial action. And that's one of the reasons why we thought it would be good to have a review of that, and that's featured in the spotlight item that's actually covered later on the agenda. But there is also a broader people theme because we've got the Grow Your Own workforce proposal as well. So I just wanted to link all those things together, which is really why it felt important to have a staff story today rather than our usual patient story, because as we all know, the two are inherently linked really, and the well-being and of our staff is strongly connected to the service and care we provide to our patients. So any questions or comments that anyone wants to make? Vicky, please.
Thank you, Katie, for that story. I was just wondering how we keep the communication up with staff across the system so they know all of the efforts that are themed through today's board meeting and, previously and ongoing, all of that work. How do we make sure that they're briefed on that and they know all the efforts that we're going to so that they can see the progress that we're making?
Thank you. Yeah, that's a conversation we've been having at HRDs, and as we go into the impact section in the agenda later today, I think there's, as I'll say there, I think there's probably more we can do on some of that marketing, but certainly all of the organisations have got quite a lot of wellbeing initiatives in place, and there's a much greater focus, I think, now on using HR business partners and the manager training and work that we're doing to make sure there's a greater focus on wellbeing and really getting that message out to the front line. So we'll pull that out a bit more. I think there is more to do, but there's certainly increased work on doing that at the moment.
Thanks, Katie.
Thank you, Vicky. Simon Trickey.
Yeah, thanks, Krishni. I mean, a bit of a reflection, really. I think it's really important that we take this into account. I was part of a national conversation yesterday that the expectation for 24-25 is that there will be less industrial action, which obviously we welcome, because therefore the management of this becomes a different task. I think the action we might face might be of a different nature than we've had over the last 12 months. And I think we're probably more concerned about some other sectors of the health and care world taking action. I think my reflection as well is understanding the widest possible impact of this is really important, both on individuals, as described in the story, but also on bank and agency temporary staffing spend to cover people on strike, and also probably on productivity, which is such a huge theme of everything we're talking about at the moment. And productivity will be hugely influenced by how staff are feeling. So actually, the widest possible perspective of the impact on industrial action, I think it's really important for us as a board, and actually for the provider boards, to really understand that, because we're going to try and drive people to be more productive. We're going to try and be more efficient and reduce waste. But actually how people are feeling, as described in the story, is a massive determinant on whether all of that will work or not. So let's be optimistic and hope the next year has less or even no instances of industrial action. But I think considering this in its widest possible sense is really important.
Thanks, Simon. And I think, you know, that sense of, you know, clearly, whilst it's challenging to deal with industrial action, I think it was important the way that our colleague, whose story Katie articulated for us, actually felt that despite everything, we were compassionate as employers towards them. And that feels really important, because, you know, we don't have any control over the pay agreement, but it's really important that our relationship with our people is maintained, and therefore that our approach actually enables that. So I just wanted to reflect that, because I think it is how we handle those moments is really important. It sounds like for that individual, they felt we collectively, the trust in particular, had handled that well, and I was really pleased to hear that. Will, please.
So yeah, and I think the really important aspect of this story that comes across is this. And I've talked to a number of clinicians on the ground who are very, very distressed at the moment, is that this isn't all about pay. And, you know, there's some things that are within our power and some things that aren't. And understanding the non-pay issues and the issue around compassion and what we do to support staff is so important for us as an ICB, because that is something which is entirely within our power. I know Kate's going to come back with a paper on this a bit later on. But I think, you know, we can focus a lot on pay and the industrial action, but it's understanding the wider context that sits within is key here, and being absolutely compassionate around that.
Thank you, Will. Stephen, please.
Yeah, I think it's just to highlight, and we've got to be really mindful of the impact on all staff, and the bit we've been particularly trying to be very mindful of is not having factions of staff and the kind of conversations that go on around that, and you've got to be seen to support. So and then the other bit that we've got to be really mindful of as well, as think, is because this does have a patient impact when we're cancelling things, and then that has an impact on staff, because quite understandably patients will ring up upset, angry, and then you've got other members of staff, usually more junior or admin, that are dealing with that. So I think the whole well-being, it's not just those staff that are direct, and we've got to really carefully manage that as we go through, because I think, as Simon highlighted, the ultimate impact will be on that productivity bit and trying to see more patients, but we've got to be very careful how we manage that going through.
Yeah, thank you very much, Stephen. David, please.
Yes, thanks, Krishna. Listening to that story, I also wanted to express respect for the thoughtful approach that our colleagues were taking there, not only on the management side, but also on the people taking industrial action, that they seem to be very mindful of the possible consequences and trying to minimise the impact. I wanted to kind of express respect for that, because that is also looking at things in the broader context and trying to make a point, but also not to damage others in making that point.
Thank you, David. And finally, Tracy.
Hi, yes, thank you. One of the things that stood out for me in there was the reference to the numbers of nursing staff going down. And I know I've only been with the organisation for a little while, but I've seen some of the HR statistics talking about the increase in substantive staff. And I wonder if there's something about making sure that message is getting through to people, that is really important to the boards across the ICB, and that it is a big focus, because from a lot of anecdotal commentary, people are leaving because there aren't enough people, which makes the job untenable, which means they then leave themselves. So it's that assurance that something's being done to make their future working arrangements easier.
Thank you, Tracy. And I think it sort of goes back to that. How do we communicate and sort of reassure people about our plans, which I think we touched on earlier as well, isn't it? So we'll loop round to that, because I think it's going to be something we need to focus on as part of that spotlight conversation we're coming to. Finally, Simon.
Thank you. Am I allowed to ask a question, Chris?
You are, Simon.
I'm not sure whether I'm here. Because, yeah, and by the way, Jo sends her apologies, but she's recently put herself up to do a sort of mystery tour of Wye Valley and Worcestershire Acute. Sat at home with her leg in plaster. So one of the things I'd like to say is, because patients actually didn't have very much conversation with us about the strikes. But we did, while the strikes were on, hear of some absolutely fantastic service that was provided in terms of speed of people moving through, for example, urgent and emergency care. And I do wonder whether, has there been any learning from how the system had to operate during the strikes that can be continued outside of the strikes, that has actually meant that services were improved for patients? And I can give you an example of where a patient went from heart attack to stent fitted in less than 2 hours, for example, during the junior doctors' strike at Worcester Royal, Stephen, which really impressive, really impressive. And it was a heart attack that the consultant subsequently said would have killed the guy if he hadn't have got urgent attention. So I just wonder whether there's any learning that you can take from, or whether anybody's looked to take any learning from the way in which the system operated during the strike, that it might then transfer to, as change the way that we work when the strikes aren't on.
Yeah, thank you, Simon. And I think it's certainly I know it's a conversation we've had about the sort of, the short-term effects in terms of how we've managed. And I know it's always difficult to say, but in the circumstances, I think we have managed reasonably well for a lot of different reasons. And I can see Jane and Mary want to come in, but I'll bring Jane in first. Thank you.
Thank you, Simon. I think we do need to be a little bit careful about conflating a individual patient story with it was better because it may always be as good as that. I mean, there certainly is learning, and but of course, during that strike action, particularly junior doctor strike action, which we've had much more of, we have consultants doing broadly junior work, and of course it's more effective and more efficient. But of course, those consultants are not doing the work they would have been doing, so it has an impact on, for example, outpatient work, and so those get longer. And also, we have to really thank those consultants for the work that they did. I mean, incredibly difficult, huge amount of extra workload for them, and certainly not sustainable in the longer term. So yes, there is learning, but some of those improvements by having the most senior person doing all of the work, it isn't necessarily a sustainable solution.
Thank you, Jane. Mary?
Thanks, Krishni. So I agree with Jane, but from an ICS perspective, we are doing events in both places to wash up from winter, and we're going to include learning from industrial action in that, because we did events, if you recall, we told you, I think June, July last year, we're getting large groups of staff together, hopefully in April, May, to learn all what we did well in winter, but also what impact of industrial action and what we learned from that. So we should be able to feed back the views from the frontline staff, and hopefully feed that back into our system working.
Thank you. So I think a really important point, Simon, that you've made about learning, which I think it is important for us to capture that. as Jane says, it's a challenge, isn't it, getting the balance right? But if there are clearly process improvement opportunities that, or alignment or skill, how we use different skills differently, that those sorts of questions clearly need to be brought out. Simon, did you want to come back in?
I did just want to push back a bit, because I think my observation in debriefing the patient about the stent was the system was actually forced to work as Stephen might have wanted the system to work, rather than anybody being there to actually not operate in the way in which I know, sitting through urgent and emergency care meetings and what have you, the senior leadership teams would want the system to work. That was my point, I guess.
Thank you, Simon. So let's take those learnings into the conversations that Mary was describing, because I think they are important. And if we are including industrial action and reflections on that, I think it's a great opportunity for us to just look at, what does that tell us, and how can we make sure that preparations for more challenging periods, which do seem to come earlier and earlier, or be pretty much sustained throughout the year at the moment, but it does at least help us, I think, to think all that through. So thank you, Simon. Thank you to everyone else for their comments. And thank you, Katie, for organising that, and to the colleague who shared their story. As I say, we'll come back to that because we've got some other people-related items that will pick up on some of those themes. So we'll revisit a couple of those areas, I'm sure. So moving on then to our strategic updates. First of all, report from Simon Trickett, please.
Thanks, Christiane. Hopefully everyone's had a chance to read the report. I'm not going to go through it in detail, but just to draw out the two asks, which are to note the refreshed joint forward plan that we have to refresh, and there's a process described within the report, to endorse the emergency planning, resilience and response annual report that we have to do every year. And then probably the two other things I would highlight. So firstly, the staff survey results have been recently published. I think there's some really encouraging trends and outcomes from that. Lots more work to do, but you will see we summarise some of the ICB staff survey elements, and we'll be looking to provide more information in the future on how the trust scores across our patch compare. So that's one thing I would highlight. And the only other thing, Christiane, is on page 5, a series of CQC inspection outcomes, both for all three trusts in various areas, and reports that have recently been published, which are important because they provide an important benchmark as to where services are. And in a couple of instances, they provide a real focus for very specific improvement work that's ongoing, that obviously the board need to be cited on. But very happy to take any questions on those items or anything else contained in the report.
Thank you, Simon. So over to colleagues for any questions or comments. It would be a first if there aren't any. That would be very unusual.
It suits me.
David.
Oh, sorry, Simon. It was on page 6, Simon, you mentioned about the single-year contract for GPs and possible consequences, and I wanted to check that we are in the planning stage to mitigate any possible, or do what are possible mitigations we could do to any possible action that might come out of that, as you've mentioned in that page.
Yeah, look, it's a really tricky one. That is that's new territory for us, really. The GP community were previously in a 5-year contract that was agreed back in 2019. This year is the first year after that 5-year contract has expired. There is clearly an issue between the government and the general practice community about the money that's on offer. I think it probably might have been okay, to be honest, until the consultants' pay offer came out that was at a much higher level than that which has been offered to general practice. It would be a real shame, and it would have huge patient impacts were practices to take any kind of action, actually, particularly in our system, because of the huge reliance that we have here on general practice. We build most of our pathways around general practice. We obviously, I think there's a referendum in the BMA are holding as to what the members of the BMA think of the contract offer. I don't think it's going to be an overwhelming support emerging from that, but let's wait and see. The assurance I can offer the board is any action that does emerge, we obviously will put a whole series of mitigations in place within our gift that we will try and cover that work and work with patients to try and manage need over that period. But I wouldn't want to preempt or even prejudge what that action would be. None of us know. We just need to see how the coming weeks and months play out, really.
Thank you.
Thank you, Simon. Vicky, please.
Thanks, Simon. I was just interested in the best use of resources section in terms of the 3-year programme. And I wasn't clear, I might have missed it, but just what's the governance process for us as a board to monitor that as it goes across the 3 years?
Yes, I think our new finance committee will be overseeing that under Rachel's chairmanship. That's obviously something that we have more latterly moved to be a formal subcommittee of the board rather than the forum we had previously. So absolutely, as I said in the comment on the people story, productivity, efficiency, those are going to be the themes of the day for this coming year and probably for the next 5 years. Actually, one of the things that emerged from the budget was quite a big commitment actually in terms of capital available from the government to support the NHS with infrastructure and technology investments, but the payoff for that is productivity and best use of resources. So we can expect, and constituent boards can expect within the system, actually in local authorities as well, there to be a huge focus on productivity. But we're fortunate, I think we've made those changes within the system that we have a dedicated point now to oversee and manage that for us.
Brilliant, thank you, Simon.
Thank you. Russell, please.
Simon, first of all, thank you for the report and your hard work and your team's hard work. I just want to focus on best value care in the right setting and all the work that's being done there. Just for members of the public, 2 observations on this. Providing care in an acute hospital is the most expensive way of providing care to you. It is on a daily basis about 5 times more expensive than providing care via domiciliary care, for example. And given the amount of medically fit for discharge patients both Worcestershire and Wye Valley are still coping with, partly for internal reasons but also for system reasons. Simon, how can we go faster on left shift to deliver best value care in the right setting at real pace and therefore help flow and really drive some savings out of the system to make us more efficient and more productive? What more do we need to do?
Russell, I've got a pretty straightforward answer for that. I think we, rather than left shift, what's happened over the last 3 or 4 years has been a bit of a right shift in that we have disproportionately and probably unknowingly, if we're brutally honest, certainly at system level, we've spent more and more money on acute capacity. So I think our overall workforce has grown by 23% over the last 5 years across the system. A huge proportion of that is in the acute sector. So the only way we can go faster on left shift is actually to be braver, to reduce some of that acute capacity and put more emphasis on the left-hand side of the pathway. That's the only thing that we can do. There are operational changes. I think there's a huge mindset shift still needed within the acute sector around the bravery to let patients go. We actually don't have much of a medically fit for discharge problem in Worcester. We have got real opportunities for improvement in Hereford, but in Worcestershire our problem is that stage before they get to medically fit that we just takes too long. We were looking at some data this morning. Our length of stay in Worcester for people aged over 65 has increased by a day and a half in the last 12 months. Those are the types of things that we need to tackle. But as ever, the availability of the capacity often drives behaviour. So if the beds are there, actually, we'll probably just keep people in for longer. The brave decision is to reduce the beds and to force different behaviour around that discharge. And I think if we're going to get into productivity seriously, that's what the next few years are going to look like. a reduction in acute capacity and some brave decisions, and a lot of focus and emphasis on how those pathways around the acute sector work, and the responsibility and accountability that they take. That's the next step for this, for me.
Thank you, Simon. And I think sort of looking at David Mahaffey here, because we did have that discussion, didn't we, at the last sort of informal development session, and that's the paper that I think you're bringing back in May, David, is that right? Is that the plan that I think I said at the beginning of the meeting around that report that you were going to?
Yeah, so the immediate plan is to have another conversation about it at the April development discussion, because we didn't get that much time in the March development discussion to do it. And also WEC, which is the Worcestershire Executive Committee, have taken away an action from the last meeting to look at what can happen in Worcestershire in response to the plan. And there's conversations to be had with One Herefordshire Partnership as well, which kind of started yesterday at the away day about what the Herefordshire response to that part of the plan is. So it's building up the kind of action plan to respond to Russell's points that we need to get in place, and then bring that report with the action plan with it, rather than just a report with a statement of facts.
Great, thank you. Hope that's helpful, everybody, in just terms of clarifying the next steps on that. So thank you, Russell, for prompting that. Jane?
Yeah, I just wanted to sort of just add to the debate a little. I'm not sure a reduction in acute capacity is realistic. Where we are now is we are way over our capacity. So we'll find generally between 40 to 60 patients outside of our bedded acute capacity. So some of those are boarded patients on the ward, so they're not in a proper bed space, and some of those are in ED waiting for a bed in the morning. Our first task is to get within our bed capacity. The thought that we could reduce that 50 patient challenge, increase that 50 patient challenge we've already got by another step, I'm not quite sure is realistic. So we've got a lot of work to do in this space. There are lots of opportunities, as Simon says, particularly in Herefordshire, around the medically fit for discharge problem that we've got both in Herefordshire and particularly with patients who come from Powys. But that would only start to close the gap we've already got, let alone reduce it even further. So I just think we need to be a bit careful about a message that says we're going to reduce acute beds, which I'm not sure is quite what Simon said, but I didn't want that to be the impression.
Thank you, Jane. No doubt these will be, unless Simon or David want to come back in, I think the place for these more detailed discussions around those issues, I suspect, are going to be at One Herefordshire Partnership and WEC, as David suggested. But Simon has put his hand up, so I'll just get him back in for final
Yeah,
comment.
I was just going to say that this in essence is the whole plan, really, isn't it? This is the centre of the pitch. It all revolves around how this works, and actually all of those pathways that sit around this, both at the front door and the back door of the hospital, and even in the prevention work, they all determine kind of how that plan evolves. I also would stress the point, we have strong place-based structures here. We're looking for ownership from the places as to how they want that to shape up in the two counties. Big local authority involvement and input into that as well. Big patient input into that. So this, in essence, is the centre of the pitch for integrated care systems, I think. So I wouldn't ever make sweeping statements that yes, we need to reduce beds, yes, we need to increase beds. It's never as straightforward as that. What we need is a system that works to maximum efficiency, and we need encouragement for the right behaviours and the right risk appetite and the right communication between the various bits of the pathway. That's where the productivity challenge all plays out, and that's what we're focused on, isn't it?
Great, thank you, Simon. Yes, we'll clearly see that work through to the next meeting through the steps that David has outlined. In terms of what's in Simon's report, there are a couple of things I think we're just specifically asked to note. The situation with the joint forward plan, which we're obviously in the process of refreshing based on the ask from NHS England, and there's a clear timescale in there for us to achieve. So we will no doubt hear more about that. Obviously, the broader content of the report is there for us to note, but we do also need to endorse the Emergency Planning Resilience and Response Annual Report, which is important for us to support here. So can I take it that we're all content with that, as colleagues have not identified any concerns around that? So thank you very much, everybody, for questions and comments, and Simon and colleagues for the report. We move on then to item 9, which is the delegation of specialised commissioning services. Mark, please.
Thank you, Krishna. I think Mary a little bit worried then she was going to be presenting that one. I'm happy to talk through this one, Chair. So, good. At the moment, as we know, specialised services are currently commissioned by NHS England. What we're asking the board for today is approval for an element of those specialised services, so 59 of the specialised service pathways, to transfer back to be commissioned by the ICB from the 1st of April 2024. As you'll see within the paper, national policy is that from the 1st of April 2025, all ICBs will receive delegation back for specialised services. So effectively what we're looking to do with our other Midlands ICBs is to go 12 months earlier effectively. You'll see within the paper then that there is a huge amount of work that's been undertaken on due diligence, as shown on page 4. We've looked at due diligence from a quality perspective, a finance perspective, and effectively crawled all over what we would look to take back, understanding the benefits and some of the opportunities around that, but also looking to understand some of the risks that come with taking that transfer back to the ICB. In terms of how this would work, we're looking at effectively a similar delegation agreement as we've got at the moment around POD. So for members of the public, that's pharmacy, ophthalmic and dentistry services. So we would work in collaboration with the other West Midlands ICBs. We would have a series of joint committees, a series of joint decision making, and also effectively a financial risk share. So we would be able to cover any risk around finance in the same way as we do at the moment around what we refer to as the POD services. In terms of then the quantum and the financial envelope for 24-25, I'd love to be able to sit here and say to you today, this is the final budget for the new year. But given we haven't got the final requirements of the planning guidance, we've got a draft quantum that we're still working through at the moment and what we expect to be in the planning guidance. But yet we can't sign that off officially and say, here is the budget. But what we have worked through is what we expect the commitments to need to be covered for 24-25. The quantum is sufficient. There is a contingency reserve within that across the West Midlands. So there is a bit of a buffer for managing some of that risk. And any commitments that we know need to happen from the 1st of April are factored into the quantum. So what we're asking for today then, Chair, is for the board to approve the delegation of the defined set of 59 specialised services and allow Simon as the ICB Chief Executive to sign that. To note the memorandum and collaboration agreement between the ICBs and the other Midlands ICBs to manage the delegated services. Note the joint working then and responsibility around decision making to the joint committees of the ICBs. And also we've included a service profile within there to show the board and the public the level of services and some of the analysis we've got around the specialised services and how we can look really to start to integrate them and include them within our pathway redesign.
Thank you, Mark. So I think there might be some questions or comments, and then we can come back to the recommendations that Mark has outlined. So first of all, Sarah Dugan, please.
Thank you. I just wanted to ask another question about level of risk, Mark. I know you just touched on it, but obviously we've been in this position before a number of times, haven't we? So the key risks are going to be around whether sufficient expertise and capacity comes across from the team currently managing this. So I suppose I'm looking for assurance that you're satisfied that sufficient expertise and capacity is being transferred over to the ICBs to manage this. And the other one was just your assessment of the level of financial risk, because we know some of these services can be more expensive and can cause greater fluctuations in financial risk. I'm just interested in a bit more on that, please, but supportive of the overall approach.
Okay, thank you, Sarah. Two good questions. So in terms of the staffing that will transfer across, so they will be hosted by Birmingham and Solihull ICB in the same way through the Office of the West Midlands. And effectively, it's the staff that are currently delivering these services for NHS England. So the right level of expertise and resource, as outlined in one of the appendices, will come across so we can continue to have that same level of service. In terms of financial risk, look, I'd love to have the crystal ball to say all these things will happen during 24-25, but given what we can see at the moment and the commitment and the spend that has been there in 23-24, we contend that the quantum will cover all of those costs. The majority of those service lines sit as a block line anyway in the contracts as part of how the specialised commissioning services are commissioned with the hospital trusts. And the fact that there is a contingency reserve set aside of 0.5%, what we would love to have a contingency reserve in the ICS, I think gives us some comfort as well that there is a buffer there to manage any areas that might step outside that plan.
Yeah, happy with that, Sarah. Thank you. Okay, Vicky, please.
Thank you, Mark. I was just interested in Appendix 2, the MOU and collaboration agreement, and intrigued, I guess is the word, about NHSE remain politically accountable to the Secretary of State and Parliament, but not directly legally responsible in terms of shortcomings and delivery failures. So I guess the normal sense of delegation would be, remaining accountable. And this was slightly different wording, so I didn't know whether there'd been any discussion on that wording.
There's been no specific discussion around that wording. I think it's partly because if supported, the Midlands area or region will be the first effectively to take the delegation of services. So there is that still direct link with NHS England because all other areas and regions will still be commissioned via NHS England. So I think as part of the first phase of transfer of these services, I think that wording has been written in a way that allows NHS England to still have that direct relationship with the Secretary of State around this. I would expect as full delegation happens for 25-26 to all ICBs, that wording will probably be revisited and more in line with what we've got around the other delegated services around pharmacy, ophthalmic and dental services.
Thanks, Mark.
Okay, thank you. David, please.
Thanks, Krishna, and thanks, Mark. Following up from Sarah's question about resources transferring across from NHSE, are there any resource implications for our own ICB, and are we able to deal with those in the coming financial year from this delegation?
Thank you. So from an ICB perspective, we are looking as well about, given we've had a running cost reduction as we go into 24-25, how we change some of the portfolios and how services are overseen from an ICB perspective. So as part of that, delegated services will sit within a portfolio that reports through to me from an accountability to the board perspective. And within that, we're just going through an exercise at the moment of looking where the expertise sits within resources and staff that we've got. Do we need to look a bit differently around where we have got some vacancies around resources that we need to build in? So from an ICB perspective, we'll make sure that we have sufficient resource in the right area and that will be led within a portfolio that oversees all delegated services.
Okay, thank you.
Thank you. Aman, please.
Thank you, Krishni. Thank you, Mark. Just want to say it's reassuring that there's been some learning from the pod delegation, and it's good to see that that's been incorporated in the due diligence. This might be a bit of a controversial one. Are we aware of any kind of legacy issues that we might inherit from the delegation from NHSE? So firstly, I'm assuming that's incorporated in terms of managing the risks, and also it'd be helpful, I think, for the public to understand what you see the benefits and opportunities of the delegation to be. If you can answer those for me, Mark, please.
Absolutely. Thank you, Aman. Okay, so from a legacy perspective, everything we've looked at from a due diligence so far, there is nothing that comes out to say there are some big legacy issues, both be good or bad, that we need to be cited on. And given we would be looking to transfer services effectively 12 months ahead of what the national timeline is for the transfer to all other ICBs, that does give us the opportunity to continue to work closely with NHS England as we go through the transition of these services, and things that may come out that we weren't aware of as part of the due diligence. In terms of the benefits for this, well, there's lots of benefits, isn't there? So the main one is around how we ensure, from a delegation perspective, it aligns to our existing pathways and the services that are currently delivered for our population and within our local hospital settings. It also gives us an equity of access oversight as well, because as we know from the whole inequalities lens and areas that we've been looking at, again, to have more control of that ourselves, again, we can then build that into the same kind of approach and work we do in terms of the equity and how we get access for services. We know at the moment, with how services are delivered within our current hospitals locally, as they're commissioned by NHS England, the whole pathway doesn't necessarily join up, and it could be a little bit more disjointed. So it gives us the opportunity to do a complete end-to-end review of the pathway, make sure it's more joined up, and make sure that when we're making decisions, it's decisions that encompass the whole pathway. And we have had issues in the past where we've kind of rubbed up against NHS England's shoulders as we've been looking at some pathways. And that whole thing then around the pathway transformation. So again, whilst specialised services are that, they are specialised, and in a number of areas there are only providers of a specialist nature that can deliver them. It does give us the ability to look at where they're delivered, how they've delivered, are there opportunities to intervene earlier in the pathway, particularly as we've just been having the whole conversation about left shift and out of hospital care. It gives us that ability to look at that as well. And we've included within the paper on page 3, Aman, a specific example around renal services and how some of the benefits might work if we were the commissioner of these pathways. So hopefully that answers your question, Aman.
Thank you.
Okay, thank you. Russell, I saw that you had put your hand up, but you okay? Okay. The board is asked to, as Mark outlined, approve the delegation of the defined set of 59 specialised acute services from the 1st of April on the basis of the responses and assurances we've had and the paper and obviously the appendices. Is the board content to approve that as outlined? Great. Okay. Thank you very much. Thank you, Mark. So we move on then to the next item, which is paper 10. Which is the investment standard, grow our own nurses. So Katie, back to you, please.
Thank you everyone. So we as a board have talked a lot, haven't we, about the need to do something differently around our workforce and put ourselves on a more strategic and long-term footing. And so this paper is a system-wide approach that we have built with pretty much representatives from all of your organisations to start to do that with nurses. So what I'm bringing to you today is a way in which we can build our own programme to grow nurses from healthcare support workers and care workers across the system to become trainee nurse associates and then fully fledged nurses after a 4-year programme. This, I won't go through all of the details because you've got the paper in front of you and I'll assume that you have read it all, but this has got backing from across the system. We've gone out and spoken to people widely and we've got a huge amount of engagement in it. The idea is that we'd invest now each year over the next few years. So we've got a 2 million investment in there per annum, and then we'd start to see agency costs come down in year 3 as we turn out more substantive nurses. And the crucial part of this is that in the longer term we need to be able to mitigate the vacancies that we've got across the system, for which we heard the impact earlier in the staff story. We have 25% of our nurses who are reaching retirement age, so we do have a cliff edge coming our way, and we are heavily reliant at the moment on international recruitment, which we know we need to bring down. It's also in the long-term workforce plan that we'll need to bring that down. So at the moment, this is a programme that we've got devised for the NHS, but we're working with primary care and social care to understand how they may be able to access that too. I appreciate the financial position, however, is difficult. We're in the middle of financial planning, and that's a difficult context, isn't it? But what I really would like to get today from the board is agreement that this is the right sense of direction and that we can start to do this, that we will trickle this through as we go, obviously in line with what's going on with the finances. Just a word on the governance. Once we have your agreement, the nurse faculty, which is the CNOs, will oversee this and make sure that it ultimately make sure that it is delivering what it says it will deliver. And we've got an implementation group, if you like, that sits beneath that to enable us to make this happen on the ground. But all of the trusts have their own programmes anyway, and this will serve to amplify those programmes and do more across the system. But I can see all the yellow coming up, so I'm going to stop there because obviously everybody's read all this, and I'll let people come in. Thank you.
Thanks, Katie. Right, yes, a lot of comments or questions coming in, so we'll take one at a time. But if we're beginning to run out of time, Katie, I might throw a few at you at the same time and pause in between. So first of all, Russell, please.
I'll go quickly. First of all, Katie, thank you for this. I'm very supportive. It seems to me to be self-evident that it's more sensible to grow our own and not incur the enormous margin that the agencies are making out of us in the NHS. I would, however, very strongly recommend we do promote the pension which employees in the NHS get. It is the best pension in the world. I heard obviously the earlier comments about pay rates in the NHS, but we should remember that the NHS contributes probably about 20% more to pension costs than a private employer would. So if we're not talking about the pension, we are doing our staff a long-term injustice. It's a wonderful pension. It's a real reason to work for the NHS, apart from all the fantastic good you can do. But thank you for the paper, Katie.
Thanks, Russell. Simon, please. Simon.
Yeah, thanks, Christian. I think it might be a record, hadn't it? 9 hands up. I'm not sure I've ever seen that, really, certainly on a board meeting. Just a bit of clarity, really. So we're 100% behind this. Katie and the team have worked really hard on this with the Trust Chief People Officers as well. To be specific about the proposal, I think what we're looking for is for the board to agree this is the right thing to do, to agree we want to do this in Herefordshire and Worcestershire. There is a timing element, though, because we currently don't have an agreed financial plan for 24-25. It isn't sensible or wise to be committing additional expenditure when that is the case. So I think we're looking for approval of this scheme and then a delegation to me and Mark as to when the timing is and how we can fit this expenditure into our plan for this year and next year. So just to be clear on that.
Thank you, Simon. That's helpful. Rachel, please.
Thank you. I think this looks like a really good proposal. What I wanted to just explore a bit is how people are going to be supported once they are recruited, and so to make sure that we retain them and keep their skills and resources within Hereford and Worcestershire.
Thank you, Rachel. Katie, do you want to come in on that? Because I think it's a really important point, because we have had there has been a bit of a challenge of I think, you know, we've talked at the people board, haven't we, the regional people board, about sort of recruiting people at, you know, at scale, and then finding that, I don't know, 50% of them have sort of left before the end of the year, and not specifically in Herefordshire and Worcestershire, but as a broad brush. I think it was particularly on healthcare support workers. So that kind of onboarding process and everything else around that, and retention is really important. So do you want to comment on that?
Yeah, I'd say two things on that. So one is that the trusts all do have these sorts of programs in place, and this is about scaling them up. So there is the support in there for the people going through these types of schemes, and they're looking at whether they need more practice supervisors and clinical educators, etc., as part of this. But we would do that as part of the programme, so we'd use the money to support that, and that's part of the steering group to look at. Healthcare support workers, this is a massive retention piece for them, because what we want to be able to do is attract them in on the basis of come to us and there is a long-term career with us, and we will help you to become a future nurse by going through this program. There's also the real value of you start to cohort people, and there's so much evidence that shows that once you've got friends in your same cohort, you will stick around for longer. There's just oodles of evidence to suggest that. So this gives us an attraction strategy and a retention strategy in one for that group.
Thank you, Katie. Really compelling. Thank you. And I'm sure you've noted Russell's earlier point about pension as well, which I know is an important point we've discussed previously. So thank you. Sarah Dugan, please.
Thanks. I think Katie's probably just covered it, but I'm fully supportive of the scheme. I was just going to raise the point about practice educators, because we are expanding the number of students we've already got on this scheme, and it's very popular, but actually that support is critical to retain them. Picking up Rachel's point, making sure we have got that practice educator support. So thank you, Katie. I know you just touched on that, but it's good to know that's being considered as part of the programme.
Thank you. Nigel, please.
Thank you. Yeah, I think this, on face value, absolutely the right thing to do. I think this is, you know, the argument is well made. I just think we just need to be a little bit mindful that general practice also has a pretty demographic trend for retirement of our practice nurses, and we, you know, our objective is to left shift. And what I wouldn't want to see is not have well-developed plans for general practice sector not being deployed at the same time as the work that's being deployed within the trusts, because you might end up with some perverse outcomes there. And so I would just like to see those firmed up a little bit stronger when we perhaps go to the implementation.
Thank you. Katie, do you want to comment on that at all?
Absolutely agree, Nigel. Those conversations are ongoing at the moment, so I'm very happy to bring something back to board just to explain that in some more detail, if that'd be helpful as we're implementing. Yeah. Thank you.
Thanks, Katie. David, please.
Yes, thanks, Krishni. I wanted to welcome it, Kate. I mean, you know this already, but I really welcome this as a great example of not only longer term thinking, but also using the power of the system to multiply the effectiveness and the impact in the trust. So I think this kind of intervention is exactly where we see some of the power of the system coming in. And the other thing was to highlight, and you have already got it in the paper, but the need to ensure that we do reap the financial benefit and the cost benefit of this later on, rather than it just being something which we embed and then forget to make sure that we reap the financial reward.
Yeah, thank you, David. I think the benefits realisation piece is one we really need to drive, don't we? And it's certainly something we've touched on before. So Emily's work on that will need to play into this, I think, because I know that's something that Emily Godfrey has been working on as well. Aman, please.
Thanks, Christian. It was really to build on the point that Rachel had raised earlier about how we ensure that they stay in the system, because I know previous board meetings we talked about placement experience and things like that. So it's not just the onboarding, it's the whole piece. But also I was just wondering, are we doing anything about upskilling our existing workforce as well? Is there any work being done around that to try and keep them in the system as well?
there's a lot of work on that, Aman. So in terms of this group, the aim is to go out and recruit locally, and we already do actually in our healthcare support worker pool, but because we're pulling from that pool, you've already got people who are committed to the area and are likely to have houses, families, friends, etc. in the area. It also offers us the opportunity to go out to those areas where we're not as well represented across our workforce, and that then speaks to some of our health inequalities and prevention work, because the more people we have representing the area, the more that are likely to stay with us and help us to do some of that prevention work in the future. So I think we've got quite a compelling way of keeping people in the system, and in my experience of these things, as you start to build that and build up that picture, that entices others to want to stay more too. So I think there's lots of retention activity going on at the moment, but this gives us another lever to do that.
Could I also ask, how are we making sure that the learning experience is going to be a good one? So if we're working with higher education institutions, how are we making sure that they're delivering on their side of the bargain as well?
Yeah, we've picked up those conversations with Worcester University at the moment. We're assuming they're our main provider. They're able to deliver. So we're talking about that through our nursing faculty. And we had a conversation at our steering group the other day for the academy, for example, on placements and the placement experience and capacity, and how we can make sure that we facilitate high quality placements. So all of those conversations are ongoing through the people infrastructure.
Thank you.
Thank you. And it sort of links very closely, doesn't it, to being an anchor institution in
Absolutely
the
right.
system, and about employing local people and supporting, it should help us with all our aims, because it's also about sort of the economic benefits of providing secure employment in our places.
Yeah.
So I think there are sort of some broader ambitions. This done well, this might help us to fulfill, which so it does feel like in many respects the right thing to do. Jane, please.
Thanks. And I was going to answer a bit of, I think, as well to Aman and Rachel's questions, because we've obviously been trailblazing this at Y Valley. So we started the work on this about 18 months ago and have been working and scaling this up. And the approach starts, this isn't about recruiting new people to put on this. The approach starts with recruiting healthcare assistants that would then say, in 2 years' time, you go from a band 2 to a band 3. You've then got the experience to then be supported on the nurse associate program, and then you can go on. So we started that conversation with our healthcare assistants over that period of time, and we have halved our turnover in that time. So, and that's very much part of this, but it absolutely is. It is our local people. That there is part of that, which is the cohorting, which is what Katie was saying. So on Monday, so we used to do 8 a year. So on Monday, 16 started. We've got another 16 starting in September. So that's quadrupling the scale of that. And also Worcester University have been fantastic, because they are a cohort who are being supported all to do all of their training in Herefordshire. So it absolutely is rooted in place. The last thing I want to say is to Nigel and to his point. And I think we have to have it of sufficient scale that we can ensure that we've got, particularly for our registered nurses, that as they come through, that our registered nurse cohort is of a sufficient scale that it meets the needs of the whole of the system. So it's not just acute and community nursing focused. And I think we've probably just got a little bit more work to do on the numbers of that to make sure it's of sufficient scale. But we've got to do some bit more work on that. But the approach that we've taken is saying we've been the leading the way on this. That impact on turnover has been so significant that's really where our big benefits are going to come from.
Thank you, Jane. And it's really helpful to sort of bring the reality of things that we've already done, and we're building on that and strengthening that and scaling it, I think is Katie's point originally, which I think is really helpful to illustrate. Mark, please.
Thank you, and Katie, thoroughly support. And as you say, we already do this, and within the trust we've been doing it a number of years to great success, but scaling it up would be fantastic. But my point I wish to make was the most difficult area is registered mental health and learning disabilities nurses. There isn't an international pipeline, so and especially the more remote rural places. So Herefordshire is a great example. So if there is any focus to be given anywhere, can I just request that registered mental health and learning disabilities nurses don't get lost in the obviously the greater numbers of physical health nurses, and we really need to ensure, because there really aren't any other avenues other than this. And so I greatly support, but a plea for mental health and LD nurses to not be forgotten.
Absolutely, and that's why it's going to be the nurses that steer how we do this, because they will be talking about absolutely what is needed. I don't see this as an HR run program. I want it to be done by the people who already know what they're doing and what they need to make sure that we get exactly that.
Thank you, Katie. Really important point, Mark, as well. Sarah Raystrick.
Excuse me again. Yeah, really supportive. I can see David's picked up the point that I was going to make in the chat as well. But I think there's a huge element here about health inequality, health equity across our patch. We know that a huge number of people who live in Herefordshire and Worcestershire work in the NHS, and the hope is that we increase that. And we know that if we've got people in fair employment with a healthy standard of living, then that reduces their own burden of ill health and reduces health inequalities within that population as well. So I think from that point of view, it's hugely beneficial. Just a quick question about us working sort of in partnership with other local providers. It's been quite topical in the news recently about childcare. If we're having a drive to recruiting what hopefully will be both men and women, but potentially more women into some of these roles, are we working with our childcare providers to ensure that that isn't a huge barrier to people entering the workforce?
Katie, do you want to comment
That's
on that?
a very good question. I know that individually trusts do some of that, but I will have to take that away and get you a more detailed answer, Sarah, if that's okay, because I haven't got that at the tips of my fingers.
Thank you. So we'll note that, Katie, is something you can follow up on. So
yeah,
that would be
course.
great. Thank you. And finally, we've got Tracy, followed by Mark. So Tracy first, please.
Thank you. Yeah, it's interesting in the staff story earlier, there was a reference to the number of nurses coming through since the bursaries have stopped. So for me, this is a great example of where equity of access to training for people who can't afford to go to university. The thing also that it's in two parts I really like, because it's not as daunting for people who are going back into education later on. They can sort of take it in bite-sized pieces. The question I'd got was around the risk in terms of capacity, and I think Jane sort of touched on that a little bit, but I did want to make sure that we weren't using up spaces that then meant there weren't as many ordinary paid spaces for students. So we weren't sort of shooting ourselves in the foot, if you will, if there's a finite capacity.
That is a really good question. It's one we've been tackling in our apprenticeship hub, which is a slight misnamed group actually, because they are looking at placement capacity and where we put our students across the system. And we just agreed at our steering group to do a bit of a deep dive into that. At the moment, we don't think it's going to be an issue. What we want to understand is, will it be an issue for the future, as particularly the long-term workforce plan sees more education happening in the workplace as opposed to in the higher education institute. So it's a potential risk for the future. It's not one over the next couple of years, but it is something we need to dive into and have a proper look at to make sure that as this continues and as this trend continues, because it won't just be nurses, ultimately there'll be a lot more apprenticeships out there, that we still have the ability to place them. And we know there's much more we can do with other system partners. There's more we can do with hospices. There's more we can do with the VCSE. There's more we can do in social care and primary care as a whole system than just rely upon our trust. So that's the piece of work we're also going to look at alongside this, so that we mitigate that risk before it comes along and gets us.
Thank you. Thank you, Katie and Tracy, for that. Mark, please.
Thank you, Chair. Katie knows I fully support this. I think it's the right thing to do, and training our own and growing our own staff is exactly where we need to be going forward. I do just have to put a note of caution though. As Simon touched on at the start, we don't have a financial plan agreed yet for 24-25. As you'll see a little bit later in the finance report, we've got a deficit position already, as we can see in 23-24. So the timing of when we implement this, we just need to make sure that fits alongside an agreed financial plan, and that when we get to the point of making that investment, that's within an overall financial strategy that allows us to get back to a balanced position.
Thank you, Mark. Thank you. One final question from me, and I will just then invite support really. Katie, just a general comment about equality of access, really, to make sure that we are thinking about, staff from all with, a range of protected characteristics having equality of access to training and program, because, we know that that's always a bit of a concern. So are we building that into the programme?
So in the implementation further on in the paper, there's the timeframes around how we do the recruitment, the application process to this programme, and as part of that there's quite a lot in the application and the assessment where we have cultural ambassadors and panels of different ethnicity, gender mixes, etc. So yes, and we will be going very hard on making sure that that's upheld throughout.
Yeah, thank you, Katie. Thank you. And I know there were a couple of references by colleagues about things that were in the chat of our meeting, which, as we know, the public can't see. So I just mention that that actually one of the comments, which I think is quite helpful, just to remind people, is that we've had recruitment staff going out on our outreach vehicles as part of our sort of approach to reaching out into the community, both in terms of supporting delivery of healthcare and promotion of healthcare, as well as in terms of attracting people for job opportunities from different parts of our community. So it's a really important sort of connected initiative, and it's worth sort of just highlighting that, really. So my sense from all the comments is that everybody is very supportive of this. And I think we've heard very clearly that it's the right direction for us to take. So unless anyone has said anything to the contrary, I think we are saying we absolutely support the direction of travel. We will ask Simon and Mark and other executive colleagues to look at how we weave this into our financial plan, given we actually are not in a position to agree one at the moment. So I think, Simon, you set that out, and Mark, obviously you highlighted the challenge of that position that we're in at the moment. But if we can delegate that to you to look at how we can take this forward, I think you have the board's full support that this should be seen as something we do invest in, because the proposal is very strong. Everyone content with that? Thank you.
Thank you, everyone. And just a big thank you to Lucy Flanagan and Jane as well, because they've provided us with a lot of support throughout this process, and I really appreciate it.
Great. Thank you, Katie. Thank you for that. We shall come back to you for another item later, so you can have a breather for now. But we have next on the agenda the ICB objectives and risk appetite for 24-25. Hannah, please.
Thank you, Chair. So this is the time of year when we need to look at the ICB objectives and risk appetite, as we did previously 12 months ago. So just to remind board members that at the last meeting in January, we have presented ICB board assurance framework, which had a look at achievement against objectives for this current financial year and a projected level of assurance. So there we have got an update on that as part of the board assurance framework item later. So I'm not going to talk about specific sort of level of assurance against individual objectives for 23-24, but instead I wanted to ask the board to approve a set of new objectives for 24-25. So in line with the refresh of the joint forward plan, this is not a kind of throw everything up in the air and start again. This is really a look back at the objectives that we had set 12 months ago and looking at what we need to update, refresh, what is no longer relevant, and where we need to make some changes. So page 2 of the report sets out the proposed objectives for the next financial year. The high level 6 objectives haven't changed, all the statements that kind of underpin them. But what we did do is we refreshed the individual deliverables and the success measures. Just a note on the success measures, obviously, given where we are with operational planning, some of the detail and some of the real kind of measurables and achievables are still lacking at this point, but they will be updated in due course. So Appendix 1 of the report sets out how these objectives that are proposed for the next financial years relate to the objectives for this current financial year and where the changes have been made. I won't go into the detail of that, but it is there for you to take a look at. We did have a discussion at the last board development session about the detail underpinning this, and some useful comments and additions were provided, which have been included since then. And then secondly, we need to set our ICB risk appetite at a kind of high strategic level. So again, we did do this 12 months ago, and we did have a designated board development session on this. So the proposal actually isn't to move away from those risk appetite statements. We feel very much in this very similar position in terms of our priorities and where our focus needs to be. But that risk appetite is set out as Appendix 2 and the specific sort of statements we are asking the board to sign up to. So obviously, risk appetite is really important for the board. It does kind of dictate and determine how we approach our management of our risks, where we need to focus our resources and effort and mitigations. So I am obviously, once this has been approved, it will inform the board assurance framework for the next financial year, both in terms of the objectives that the board assurance framework is based upon, and also the target risk scores that we assign to individual risks that sit within the board assurance framework. So today I'm asking you to approve the refreshed ICB objectives and priorities for 24-25 and the risk appetite for 24-25. Thank you.
Thank you, Hannah. Any comments or questions? As Hannah said, we did consider this, I think, briefly at our board development informal session, but it really is a refresh and just a refocus on some areas which just benefited from that. So everyone, unless there are any questions, everyone content to approve those? Great. Okay. Thank you very much, everybody. I think we have earned a short break. So if everyone's content, we will reconvene at 11 o'clock and move on to the next item. So I suggest we just turn our camera and microphone off. And as I say, we'll restart the meeting at 11. Thank you. Okay, welcome back everybody. Let's make a start. The next item on our agenda, item 12, Committee Escalation Assurance Report. I think because there are have been some committee effectiveness reviews, I'll invite Hannah to comment on those first and foremost. So Hannah first, please.
Thank you, Chair. Yes, so we conducted our annual committee effectiveness reviews for all committees, and those are summarised. The findings of that are summarised on page 3 of the report. By and large, the changes are related to membership changes, predominantly because we've got 2 new non-executive members, and so we've made some committee changes, and I've already reported on those to the last board meeting, and some minor changes and amends to committee operations as detailed in the table on page 3. So as a result, we then amended terms of reference, which are enclosed to this report as Appendix 2. And then I just wanted to also say that resulting from that, we needed to make some changes to the scheme of reservation and delegation for the ICB. And again, those are listed all on page 4. So some of those relate to committee changes. Some of them also relate to PSR, provider selection regime, developments and changes, which again we discussed at the last board meeting in January. So for my part, I'm asking the board to formally note the outcomes of the committee effectiveness and the terms of reference and scheme of reservation and delegation. And I will hand over to Krishna and the individual chairs in terms of the rest of the report.
Thank you, Hannah. Can I just invite chairs to raise their hand if they wish to come in and comment on anything within their committee or bring anything in particular to the attention of the board? On the basis that I can't see anything there, I'll just ask any other members of the board if they have any questions about the content of any of the reports. Obviously, therefore, the visibility and transparency for the board to be assured about the committee's function. So I can't see any comments. So can I just invite board members then to approve the suite of terms of reference and the scheme of reservation and delegation, and obviously note the remainder of the assurances and items highlighted in the report. So everyone content to provide those approvals? Great, thank you very much. Thank you, Hannah, as well, and thank you, committee chairs, for the reports. So we move on then to our spotlight session, which links very much to the story we had at the start of the meeting, and it's a follow-up action that we agreed from some months back around that broader issue of impact of industrial action and health and well-being. So Katie, over to you, please.
Thank you. Yep, well, you've heard the story and hopefully you've had a chance to go through the paper. So I'll just pull out a few bits and pieces as I go through. So the paper is drawn from a number of different sources. So where we've been able to talk to people individually, we've put that in. But as I said at the beginning, we've struggled to get some very individual stories throughout. We have, however, gone out to all of the occupational health teams across the system and the HR teams and asked them for their input. So the section that explains what the impact has been on staff comes primarily from those sources. We've put a little piece in there about how the system's been preparing for strike action, so that you can see the kind of levels of activity that have gone on each time we've known that strike action is going to take place. And I think generally it's been seen across the system, and it was referenced this morning, that we've dealt with it pretty well in terms of the planning. And I think it's helped because there have been members of staff very comfortable telling us whether they intend to go out on strike or not. But there is always that risk that we won't know until the day. The piece around the responses from each of the organisations comes from the HR teams, and just to pull out, they are doing quite a lot of getting out to the front line, talking to people, using HR business partners to explain what well-being we have in place, etc. So there is a kind of real sort of board through to the front line approach in trying to make sure that everybody understands the support that's available to them. I then thought, given that we'd got the staff survey results for the NHS, it was well worth giving you a bit of an oversight of what they're starting to tell us. I've only pulled out the 4 questions that I think really could be directly relatable to what we're talking about here. If you do want to go in and look at all of the results, they're on the gov.uk website, and you can get to the NHS staff survey results and go into those by question, by organisation. But what we're seeing there is a slight uptick in across the system. We're seeing an uptick in the staff survey engagement. Some organisations have seen quite a big uptick in that. But generally, I guess it's starting to paint a stabilising picture. Sickness levels are still higher than most people would like, albeit that they're on plan. And so the work that's ongoing at the moment is really getting, as I say, selling those well-being initiatives and support out to the people who are delivering our services on the front line. The thing that I think from a system perspective, obviously trusts will probably want to talk to their own well-being, as will the councils and primary care, but the thing that I think we need to do from a system perspective is really understand the plethora of well-being initiatives that we've got and where we can share those more broadly and how we communicate them more to our teams as part of that piece on these are all the things we're doing to support you. Each individual person out there working will know what their organisation's got available, but they may not be aware of some of the broader initiatives that they could also access. So we're going to look at trying to do some of that through the Great Place to Work work stream under the People Board and putting some of those onto the Academy so that everybody across the system can access them. So those are the key things I was going to pull out, but I thought you'd prefer to use the majority of the time for questions and answers, Chair, so I'll hand back to you.
Thank you, Katie, and we'll go straight into any questions that are forthcoming. So David, please.
Yes, thank you very much. Thanks, Katie, and really welcoming the ensuring that individual wellbeing initiatives from each organisation are actually being well communicated. But a question, did we not last year or year before have a system wellbeing programme? And if I remember correctly, we ended up cancelling that system-wide wellbeing programme. Would it be right to reconsider that and to see whether we can find money for a system programme again?
We did. There was during COVID, there was some money provided by NHSE to set up a wellbeing hub for the system as a whole, and that then we put in place extra staffing and support to do that, and it was run from the Health and Care Trust. It was a shame when that funding went, particularly given the emphasis on retention in the long-term workforce plan. However, it was quite an expensive thing to run, and the take up of it was not huge because of the fact that other organisations were already offering a range of initiatives to their own staff. So I think what we'd prefer to do going forwards is more of a gap analysis and looking to fill in the gaps rather than overlaying something over the top of what everybody else is already doing.
Thank you.
Thanks very much. Any other comments or questions? I know we touched on this anyway earlier, so looks like we've sort of raised the issues we wanted to. And I think what you've highlighted, Katie, is that a couple of people said earlier the importance of communication and making sure that people really understand what is available to them. And I guess, you know, given resources are tight, sharing whatever resources we can reasonably share or appropriately share, so that we do collectively offer the best we can. There is just one thing that I wasn't, and one can argue about the rightness of doing this, but I have seen in other systems the use of charitable funds to support wellbeing initiatives, and I just wondered whether that's something. I can see that Jane and others are sort of nodding that might be being done locally within your own trust setting, but I just wondered if that's something we want to explore or have explored. Did anyone want to come in on that? Russell, were you going to come in on that?
Yeah, Krishni, certainly across Worcestershire and Wye Valley sites, we do use charitable funds to support staff wellbeing when appropriate and not part of what would be described as core funding.
Yeah, thank you, Russell. And I think Sarah also indicated that. Mark, do you want to come in?
Just to say exactly the same as Russell at the Health and Care Trust with the charitable fund.
Yeah. So that is just something to be mindful of, that you know, I think there is an opportunity for us to consider. I mean, obviously very, you know, carefully and appropriately, but use of those kinds of resources to help support staff wellbeing, which I think has been helpful in many settings. A couple of other things really. I think Simon mentioned at the beginning, although obviously in the Chief Exec's report we pulled out the staff survey results for the ICB, can we check, Katie, whether the People Board will be just doing a system-wide review of common themes in terms of staff survey? Because if there are, again, things that are common to the system, it may be that a system solution would be helpful to explore. So just any thoughts on that?
Yeah, absolutely. That's on the agenda for the next People Board. So at the moment, each organisation is taking its results and going out and speaking to staff and coming up with their approach and trying to make that as local as possible. So getting down to individual teams where they can. That then gets collated back up. We will look at it collectively between us at the People Board and pull out anything that does work at a system level. It's a tricky one because there's huge amounts going on out there, and duplication can often be really confusing for staff if we're offering one thing and then there's another. And actually so much of this is about really good line management and people checking you're okay and making sure they're spotting if it looks like you're having a wobble. Good well-being conversations, that's where the real value sits in terms of well-being and avoiding sickness, isn't it? But what we do want to do is just make sure we don't have a gap in the offers that we can have. And so part of our work is looking at what other ICSs have across, certainly across the region, but we're also linked in nationally. And if there's anything that we've not got that may be a good idea, we'll be talking about that through the People Board infrastructure.
Great, thank you, Katie. So I can see that there are no more comments or questions, so we are really I think on the back of what you've just said, Katie, you're looking at system provision from in terms of wellbeing initiatives, making sure that the organisations are adequately supported, but recognising that organisations themselves will have those offers in place, and it's just a sort of coordinating role and a gap analysis. We'll leave you to do some analysis around the staff survey results from a system perspective, and it would be useful, I think, through Simon's report to just feed anything back that we think we need to be aware of, that might, you know, I think be a common theme across the system, that collectively we ought to be aware of, I think would be useful. Thank you very much. Otherwise, we note the content of that update and move on to our next item. So over to you, Mary, for the System Quality and Delivery Report.
Thank you, Krishni. So obviously this report highlights the work of our system in relation to the key quality and delivery outcomes for our population. So I'm just going to pick up the high level areas of risk that we have. Urgent care, there's three aspects I'd just like to take you through. Firstly, ambulance handover delays. I'm delighted to report to you we have seen improvement in our ambulance handover delays. We see less delays in length of time and less often days where we have problems. We still have some days where we do have delays, but it's a lot less than it was in the previous sort of 6 months. So the last 6 weeks particularly, we have seen an improvement, and we've been encouraging that to continue. So that's really positive for us. March for the whole country has been the focus on the 76% 4-hour standard in ED, and for the public that's patients seen, treated and discharged within 4 hours, and the target for us for March is 76%. Again, we started in a quite challenging position as an ICS, but again delighted to report in the last sort of 3 weeks we have made a 10% improvement across our system. Still a challenge to get to 76%, but we have seen days in both our trusts across the 3 sites where we have come very close to that, and we're encouraging a continued improvement. That's a mixture of turbocharging the urgent care plan delivery that we've talked about many times at this meeting, some increased recording and validation of breaches, and a complete focus from a system. And there's national learning that this is working across the whole country to see improvements. So the next 2 weeks are crucial for us to see how close we can get to that 76% target in our system. But good to see that improvement. And then lastly, for urgent care, our urgent care board signed off the urgent care strategy for our system, which takes us through to 2028. And we'll be making sure that's fully embedded in practice across the whole ICS. So that's urgent care as an area. Moving on to elective. So we know from previous discussions, our focus has been on no patients waiting more than 78 weeks for elective care treatment. We had a challenging year in relation to this, but again, we've seen some improvements, quite a lot of improvement recently. The impact of industrial action, not as great as we thought, but we are now predicting that we'll be at 31 patients at the end of March. That will be breaching our 78 weeks, but I'm aware that the teams, as we speak, are really working hard to bring that down even further. But from where we were, that's a significant improvement. We still remain tier 1 in some of our tier 2 in some of our areas, but we are making sure that we are taking all the actions we can to reduce that number further. And the bigger challenge will be to get to 0, 65 weeks in September. Again, a lot of work to make that happen. Our cancer services, one of our biggest high-risk areas. We were in a very challenged position for our 62-day cancer standard. That's a 62-day treatment for cancer. Again, really pleased to be able to report to you an even more up-to-date picture than it was in the paper. We are now, our target was for 261 patients across our ICS waiting for treatment of cancer over 62 days at the end of March. We're currently at 280 as of last Sunday, which is a significant improvement in the last 2 weeks. And a lot of that is across our 2 very challenged specialties of urology and skin. So we're really, really pleased to see the improvement in that position, and we look forward to bringing that 280 down even further by the end of the month. So still a lot more to focus on in our cancer pathways to get those best practice time pathways across all our specialties sustainable for going future, but it's a really good move in the right direction for us. So some really pleasing news to be able to tell the board at the moment. We just need to continue that. The rest of the report is for information, and happy to take any questions. And I've got Rachel with me and Katie. Any questions on the quality section and the workforce section. And just finally to note, the 2 risks our risk QRD committee have removed, just your detailed on page 4. They have now been risk register numbers reduced, so they're now sustainable and business as usual.
Thank you very much, Mary. Russell, please.
I'd first of all just like to apologise to members of the public who are listening in or watching in for the delays they are still experiencing. We all recognise that the delays are still too long. Having said that, I'd like to thank Mary, all of the teams at Worcestershire and Wye who have worked together really well to drive the numbers to where they are now. The trajectory improvement has been fantastic. So thank you to everyone that's been involved. We all appreciate you going the extra yard, putting in the extra effort to do what we've done, albeit we recognise we've still got a long way to go.
Thank you, Russell, and I'm sure we'd all echo that thank you and recognition that there's more work to be done, but clearly that the improvement story that Mary has outlined is really good to hear. Simon?
Yeah, I don't want to repeat what Russell said, but there's a lot of work still to be done, but we do just need to take stock of it. The improvements that Mary's described are massive, absolutely enormous. I would go as far to say, I think the improvements outlined will probably make us the fastest improving system in the country, some of the strides that have been made in those key areas. So yes, there's a whole lot more work to do. We need to and will do a lot better, but credit to Jane, Stephen, Sarah, and all of the teams for the work they've done, because since January we've seen quite a turnaround in these key areas. And as we know, that's really important on a whole number of levels. Yes, on an individual patient level, on a system credibility level, it's important with the politicians. It has a whole load of impacts outside of the service. So it's worth stopping and reflecting, I think, as a board, that actually we are moving at pace in the right direction. So we just need to keep it up, don't we?
Thank you, Simon. Absolutely echo that. Vicky, please.
Thank you, Mary, and it's great to hear some of the really positive progress. I guess my question is, do we understand the key areas where of the action plan, because we've had an action plan in place for quite a while, which are the key factors of that action plan which have enabled these improvements to have been made? And I guess that by asking that question so that we can sustain those improvements.
Yeah, interesting question, Vicky. So some of this is good ICS joined up working. There's no doubt about that. How people are working together now is greatly improved. Some of it is operational changes that have been made. I think a very frontline staffing level and encouraging staff to use best practice pathways. And some of it has been that real, and credit to the national team. They've given us a real push on 76%. This is the target we should be achieving in March. It has focused the whole country back to some of the processes that we had in place probably pre-COVID. We're now putting back in place. We've had some tester change. I know Jane's doing a tester change at Wye Valley, and I know Stephen is doing different things at Worcester Acute. That seems to be reaping some benefits. But we need to continue this now and can embed it. And one of the things we need to do, and I know David asked me this yesterday, our workforce, we need to spend some time with our workforce, aligned to the previous discussions, about what good looks like and what best practice is, and try and embed that and make it business as usual.
Thank you, Mary, because it does require sort of a sustained leadership effort and a sort of support really to try and maintain these things, isn't it? Because I suspect some of it, as you say, it's always a mix of things, but being clear about what works does help, and it's not always easy, I suspect. I mean, Jane and others will know better than I to pin that down exactly, but some of it is, good oversight, some of it will be good control, some of it will be change in process, and clinical engagement, I'm sure, as well. Simon, please, Simon Adam.
Well, I was just going to say, I've sat through so many meetings over the last 10 years where it's been doom and gloom, to be quite honest with you, that just to echo what has already been said and Simon said, this is really, really good news. Particularly, some of the comments that Mary's just made that sort of demonstrate that this might be sustainable. I just wonder whether or not you've got to the point, Simon, where you think you can share some of this good news. Maybe. Yeah.